Hello, my name is Chris Balestro, and over the next 30 to 40 minutes, I'm going to review bone scintigraphy in various metabolic, traumatic, and vascular conditions. In terms of disclosures, I have nothing to disclose. It was first recognized nearly 100 years ago in the 1920s that radioactive material accumulates in the skeleton. In the 1950s, with the development of the rectilinear scanner, it was possible to image the skeletal system. In the 1970s, the nearly simultaneous development of the gamma camera and the technetium-99m labeled compounds made bone scanning widely available. In the 1980s, we had the development of cross-sectional imaging for nuclear medicine, SPECT, single photon emission computed tomography, and of course, most recently, the advent of hybrid imaging, SPECT-CT. This is an anterior view from a fluorine 18 rectilinear bone scan. This patient had Paget's disease of the skull. This scan took nearly an hour to acquire, and notice the extremely limited resolution. It is virtually impossible to resolve individual ribs and even the individual vertebrae. This is one of the earlier attempts at performing a whole body bone scan using the gamma camera and technetium-99m polyphosphates. The cameras were not sufficiently large to include the entire width of an average individual, and so the camera scanned half of the patient in one direction, then reverse direction and scanned the other half of the patient. The two halves were then knitted electronically. However, as you can see from this illustration, that electronic knitting didn't always work. This is a state-of-the-art whole-body bone scan on a dual-head gamma camera, single-pass anterior and posterior views. The whole scan takes somewhere between 15 and 20 minutes to acquire. This is an axial image from a SPECT bone scan. You can see the area of increased activity extending anteriorly off the vertebral body, which confirms that this focus is degenerative in nature. This is a modern-day SPECT-CT. You can see the area of increased activity in the mid-lumbar spine on the MIP image. And on the SPECT-CT, you can see this area of increased activity lies within the L3 vertebra, which in fact turns out to be a vertebral hemangioma. Bone scintigraphy has long had an important role in the evaluation of trauma. Bone scan detects traumatic changes sooner than X-ray and CT. The time course is similar to that of MRI, but an important advantage of scintigraphy is it permits imaging of the entire skeleton, thereby facilitating detection of unsuspected foci. This patient had an occult fracture of the left femoral neck. The radiograph is negative. The bone scan is positive, and the fracture is subsequently identified on a CT scan. This is an example of a sacral insufficiency fracture. It's sometimes described as the H sign or the Honda sign or the butterfly sign. Remember that you do not need to elicit an antecedent history of trauma. All it takes is for an osteoporotic patient to sit down a bit too abruptly on a hard surface, and that individual can go on and develop one of these sacral insufficiency fractures. Bone scintigraphy is also used in the evaluation of various types of stress fractures. For metatarsal stress fractures, it's often been the reference standard for diagnosis. For tibial stress fractures and for pars fractures, such as in spondylolysis, it offers prognostic information. In patients with vertebral compression fractures, the bone scan can confirm that, in fact, the compression fracture is the cause of the patient's pain. It can help determine the relative age of the fracture, i.e. acute or remote. And finally, it can provide alternative diagnoses to explain the patient's symptoms. This is an example of a metatarsal stress fracture involving the second metatarsal of the right foot. There's focal hyperperfusion, focal hyperemia, and focally increased uptake in that bone on the skeletal phase. Toddler's fractures typically occur in recently ambulatory children. They usually involve the tibial shaft. The bone scan is more sensitive than the X-ray, and as already mentioned, when performed as a whole body scan, it can identify remote sites of trauma. This is a patient with bilateral pars fractures. Notice that there is increased uptake in the right pars fracture, but not on the left. That indicates that healing is still going on the right, but there is no more healing, or the healing has ceased on the left. In avascular necrosis, the death of the osteocytes occur rapidly, typically within about 12 hours of the vascular insult. Photopenia develops within 72 hours. The surrounding bone becomes hyperemic, and revascularization from the surrounding tissue starts within a few weeks. The scintigraphic appearance of avascular necrosis depends on the interval between insult and imaging, as this series of images demonstrates. Spontaneous osteonecrosis of the knee is typically seen in the knees and sometimes in the hips of elderly osteoporotic individuals. It is more frequently seen in women than in men. There typically is no antecedent history of trauma, and radiographs are normal. Spunk most often involves the medial femoral condyle, but it also can involve the lateral femoral condyle as well as the tibial plateaus. Bone scintigraphy is the best imaging test for diagnosing complex regional pain syndrome. The classical presentation of the complex regional pain syndrome on the three-phase bone scan is diffuse hyperperfusion, diffuse hyperemia, and diffuse intense periarticular uptake on the skeletal phase. It is important to note that complex regional pain syndrome is positive in all three phases in only about half of the cases, period. If on the skeletal images there is diffusely increased radiopharmaceutical uptake, which is particularly intense in a periarticular distribution, that is sufficient to make the diagnosis. Occasionally, complex regional pain syndrome presents as decreased rather than increased uptake. This is the so-called vasoconstrictive phase of this disorder, and it's illustrated in this patient here. This was a pre-adolescent girl who had suffered an athletic injury a month or two prior to imaging and was complaining about left lower extremity pain. As you can see from these images, there is decreased blood flow, decreased soft tissue uptake, and decreased bony uptake on the delayed images. This whole body scan illustrates, I think, more dramatically the extent of the decreased uptake involving the entire left lower extremity. The decreased uptake presentation is uncommon and is most often seen in children and adolescents. Fibrous dysplasia is a sporadic, benign disorder of unknown etiology. It can be monostotic or polyostotic, and when it's polyostotic, as this case illustrates, it's typically ipsilateral. Albright syndrome is characterized by polyostotic fibrous dysplasia, skin pigmentation, endocrine abnormalities. Skeletal scintigraphy is characterized by intense bony uptake in the affected bones, and the value of the bone scan is to detect the extent of disease. Paget's disease is a benign focal disorder of skeletal metabolism. The bones become enlarged, irregular, and deformed. On bone scintigraphy, the involved bones are characterized by intensely increased uptake. The bone scan is useful for determining the extent of disease, but has a limited role for monitoring treatment response. The one exception to the intensely increased activity is osteoporosis circumscripta in the skull, which presents as an area of decreased uptake. This is a patient with Paget's disease in the lumbar spine. Notice the pattern of uptake in the lumbar spine. This is often described as the Mickey Mouse sign, or the champagne glass sign, or the T sign. Whenever you see this appearance in the spine, it is virtually pathognomonic of Paget's disease, regardless of what the underlying history might be. It's not always easy to differentiate between fibrous dysplasia and Paget's disease, but in patients with polyostotic disease, for fibrous dysplasia, the abnormalities are invariably ipsilateral on the same side of the body, as you can see in this case here, where all the lesions involve the left side of the skeleton. Paget's disease, however, tends to be bilateral or asymmetric, it's sometimes described, in the setting of polyostotic disease. And in the illustration on the right, there is increased activity in the bones of the left lower extremity as well as the right humerus. This is a youngster with an osteoid osteoma in the distal right femur, and this is a very nice illustration of the double density sign. On the skeletal and SPECT images, there is a focus of increased activity in the distal right femoral shaft, surrounded by a larger, more diffuse, less intense area of activity. This is the double density sign, and when present, it is highly suspicious for osteoid osteoma. This is an example of a metabolic superscan. Metabolic superscans are most often secondary to chronic renal disease, and these scans are characterized by diffusely increased radiopharmaceutical uptake throughout the axial and appendicular skeletons, and this uptake is most pronounced in the skull and mandible. These are examples of superscans. Notice that in the metastatic superscan on the left, the abnormal activity terminates abruptly in the distal humeri and distal femurs. Compare that with the metabolic superscan on the far right, where the abnormal activity extends all the way into the distal extremities. It has been suggested that it is possible to differentiate between the metastatic and metabolic superscan based on the different distribution of activity, i.e., in the metastatic superscan, the activity terminates abruptly in the distal femurs and humeri, whereas in the metabolic superscan it extends all the way into the distal extremities. However, as that metastatic superscan in the middle demonstrates, the abnormality at times can extend all the way into the distal extremities, much the way it does on the metabolic superscan. A more reliable method for differentiating between a metabolic and a metastatic superscan is to evaluate the intensity of uptake in the skull and mandible. In general, the uptake in the skull and mandible of a patient with a metabolic superscan is out of proportion proportion to the rest of the skeleton. That is not the case with the metastatic superscan. The explanation for this is uncertain. It has been suggested that perhaps because the majority of patients with metabolic superscans suffer from chronic renal disease and are generally severely anemic, that this increased activity in the skull and mandible reflects hypercellular marrow. But that is only a theory. Typically, when we evaluate bone scans, we associate areas of increased uptake with abnormalities. However, it's important to recognize that areas of decreased uptake on bone scans can also reflect abnormalities, and decreased uptake or photopenic defects are associated with tumors, both benign and malignant, the late phase of radiation osteitis, the acute phase of avascular necrosis, which you've already seen, occasionally even osteomyelitis or septic arthritis, particularly in the hip. And the mechanism for this is the fact that there's increased intracapsular pressure, which compromises vascular supply. Other conditions that will result in photopenia on bone scans include gangrene, frostbite, congenital absence of a bone, and artifacts such as pacemakers, jewelry, and clothing. This is an example of a youngster with Langerhans cell histiocytosis. Notice the areas of decreased uptake in the skull. While there are other conditions that can produce photopenic defects in the skull, whenever you see photopenic defects in the skull of a child, you should make sure to include Langerhans cell histiocytosis. In addition to that, notice the area of increased activity in the left clavicle, as well as in left posterolateral ribs, both upper and lower. These are other sites of Langerhans cell histiocytosis. And remember also that LCH has a rather broad spectrum of presentations on bone scintigraphy. These lesions can present as areas of decreased uptake, as we see in the skull, as well as areas of increased uptake, as we see in the clavicle and ribs, but they can also be isointense, i.e. indistinguishable from adjacent bone. This is a photopenic metastasis in L1, metastatic disease from neuroblastoma. Note the uniformly decreased area of activity in the upper and mid-thoracic spine. These are the late effects of previous radiation therapy. In general, decreased uptake begins about 2 months after completion of treatment and reaches a nadir by 6 months. Occasionally, over time, activity in the irradiated bone may return to pre-treatment levels. This is a somewhat unusual artifact. It actually turned out to be a cement photopenia. This is a woman with metastatic breast carcinoma and a left hip arthroplasty. We were unsure what this photopenia was due to, so we went ahead and performed SPECT-CT. On the SPECT-CT, it is evident that that photopenic defect is secondary to the large area of cement surrounding the distal tip of the femoral component of that hip arthroplasty. This is a pacemaker artifact overlying the left upper anterior chest wall. Notice also the large area of photopenia in the right knee, which is caused by the patient's right knee arthroplasty. Extraosseous activity can be seen from time to time on bone scans. Probably the most common cause is a previous nuclear medicine procedure, and whenever you see this extraosseous activity, that's the first thing to be questioned. Has this patient recently had another nuclear medicine procedure? It can be due to technical factors. It can also be seen in a variety of benign and malignant conditions, including neoplasms, trauma, inflammation, ischemia, and various endocrine disorders. The etiology is multifactorial, consists of adsorption of the radiopharmaceutical onto tissue calcium, the formation of denatured protein complexes, iron deposits, combination of hyperemia and altered capillary membrane permeability, and finally tissue enzyme binding. This is an example of a patient who had recently undergone a MIBI myocardial perfusion imaging study, and you can see the diffuse activity within the transverse colon. This is a youngster who had recently undergone I-131 MIBG therapy, and the liver activity on this bone scan reflects the I-131 MIBG accumulation within that organ. This is a comparison of one patient with free protectanate versus another with soft tissue calcification. In the illustration on the left, the activity is within the gastric lumen, as well as the thyroid gland and oral cavity, which tells us that there is free protectanate present. In the image on the right, there is activity within the gastric wall, not the gastric lumen. There is no thyroid or oral cavity activity. There is, however, myocardial uptake as well as bilateral pulmonary and liver uptake. Note in this patient there is a combination of gallbladder and bowel activity. This is due to a technical failure with the preparation of the bone agent. It may in fact be secondary to aluminum breakthrough. This is a patient with heterotopic ossification in the right thigh. Myocardial uptake is seen from time to time on bone scans. There are numerous causes of myocardial uptake of technetium-99m, MDP, or HDP. Probably the most common cause is residual activity from a recent myocardial perfusion scan. Recent myocardial infarction can also present as areas of increased uptake on the bone scan. Unstable angina, myocarditis, congestive heart failure, myocardial contusions, recent cardioversion, sarcoid, and amyloid. This is a patient with sickle cell disease. Note the splenic uptake. The most common cause of splenic uptake on a bone scan in the United States is sickle cell disease. Notice also the areas of irregularly increased and decreased activity in the lower extremities, reflecting areas of infarction and healing. This is a youngster with a neuroblastoma. And remember that when you are looking at a bone scan of a child, whenever you see soft tissue uptake in either the abdomen or the thorax, you should think very carefully about the possibility that this represents a neuroblastoma. This is a patient with metastatic osteogenic sarcoma. Notice the intense uptake in the metastatic deposit. This is an example of the uterine blush on a three-phase bone scan, and when you look at the flow study, it's easy to misinterpret the uterine activity as bladder activity. However, if you think about renal scans, you do not see bladder activity until about 3 to 5 minutes after the injection. So on a three-phase bone scan, it would be extremely unlikely to see urinary bladder activity within the first minute after administration of the radiopharmaceutical. The uterine blush is again seen on the blood pool image quite nicely, but it has disappeared on the delayed bone images. On the delayed bone image, you're looking at bladder activity. This is an example of a patient with diffuse rhabdomyolysis. secondary to statin administration. Whenever you see diffusely increased uptake in the soft tissues, particularly when the distribution resembles muscular bundles, you should entertain the diagnosis of rhabdomyolysis. A history of statins is a good clue, as is the presence of dark urine. This is a patient with a renal transplant in the right iliac fossa. When you evaluate bone scans, you should look not only at the bones, but at the urinary tract and the soft tissues. And in this patient, while you can clearly see abundant bladder activity, the kidneys are seen faintly, if at all. So therefore, you need to look elsewhere to see if whether there's a tonic kidney or perhaps, as this case illustrates, a renal transplant. This is the SPECT CT of that patient. You can clearly see the renal transplant impinging on the urinary bladder. This is a patient with obvious metastatic disease to the skeleton. Notice the diffuse colonic activity secondary to a previous MIBI study. Very similar appearance, except that in this case, the colonic activity is secondary to a vesicocolic fistula in a patient with bladder carcinoma. SPECT CT offers significant advantages when performing bone scintigraphy, or for that matter, almost any nuclear medicine procedure. Number one, we often don't think about it. It improves image quality merely by virtue of the attenuation correction afforded by the CT component of the examination. SPECT CT provides direct correlation of bone pathology with various anatomic structures, thereby reduces equivocal findings, improves test accuracy, and optimizes the selection of subsequent imaging tests. This is an example of a patient with heterotopic ossification. On the planar image, there's a focus of activity overlying the distal right femur. It looks to be a little bit high for the patella, although it could be a dislocated patella. It's hard to tell precisely what it is. On the SPECT CT, however, the area of increased uptake corresponds to an area of heterotopic ossification in the distal right thigh. This patient had a calcified thyroid nodule in the right lower neck. On the bone scan, that focus is actually fairly subtle, could easily have been dismissed as degenerative changes, except that those typically present on the posterior as opposed to the anterior views of the cervical spine. On the SPECT CT, it can be clearly seen that this focus of activity lies within a calcified thyroid nodule. This is the last case. I showed you this earlier in the presentation. This is a patient with a vertebral hemangioma. On the planar images, there's the area of increased activity in the mid-lumbar spine. On the fused images, there's increased activity in the L3 vertebra, and on the CT component of the examination, the vertebral hemangioma is easily appreciated. It goes without saying that the more sophisticated the CT component of your SPECT CT or even your PET CT system is, the more diagnostic conclusions you will be able to form. This concludes this session, and I hope that you found my presentation useful. Thank you.